I think, and I'm hopeful that in general we make a big shift from seeing entering aged care home or living in aged care home being sort of your end of life versus actually being a stage of life, albeit perhaps your last stage of life. In the past, there was something called collaborative care where a nurse practitioner had to work with a GP. There is not that requirement anymore, but I still believe collaboration in the true sense is critical.
Welcome back to Talking Aged Care, the podcast where we explore the shifts, challenges and breakthroughs shaping aged care in Australia. Today, we're joined by someone who sees the sector from an angle most never do. A general practitioner working across multiple residential aged care homes, deeply involved in clinical governance, workforce improvement and modern models of care. Dr. Aggarwal has become a respected voice in bringing GPs, nurse practitioners, nurses and care teams together to lift clinical standards. His perspective spans policy, medication safety, family engagement and the everyday challenges older Australians face. Harsh, welcome to the show. Great to have you here.
Thanks, Mark. Yeah, thank you. Thanks for having me.
Oh, fantastic. So before we dive in, what's one pressing issue in the aged care sector that keeps you up at night?
Well, Mark, I'm not sure there's only just one, but look, I think one of the biggest issues at the moment is that we do have a largely aging population in Australia, and there's more and more GPs who are actually exiting the provision of services in nursing homes, in residential aged care homes these days. Partly that's because of the political scenarios, the reimbursements, the multiple governance issues that nursing homes face and the pressures that imparts onto the GPs visiting. So that's something that I'm constantly thinking about how to bridge or help bridge that gap, because one day we'll be there or our parents are going to be there, and we want to be able to provide them what's the best possible.
Agreed. No, very, very well said, and a lot of important points. I think the concern that I can see happening a lot, and it's the same in the UK, that a lot of experienced clinicians like yourself, we want to retain experienced clinicians to obviously mentor the younger general practitioners coming in, effectively learning the ropes and understanding resi care. But sometimes that's it. They decide to exit. They prefer, we're going to stay in practice. There's that many, patients to see, from a primary healthcare perspective. And, resi aged care is missing out because of the legislation, the administrative burden.
Absolutely, Mark. And our college, the College of General Practice, doesn't acknowledge training for registrars visiting aged cares as legitimate comprehensive general practice. So we've got long ways to go to get people.
That's right. That's right. Let's start with something positive, because I guess momentum matters. As a GP working across multiple homes, what's the biggest shift you've seen in aged care over the last 12 months?
Mark, look, that's a good question. Look, I suppose, especially from my side, one of the things that I'm working towards and that I've noticed happen is a move towards team-based clinical care, and where more and more nurses and nurse practitioners and GPs are working alongside other allied health practitioners as well, communicating better. Um, and while I'm not sure that it's due to homes investing in increased clinical governance, or whether it's nurses who have slightly more experience working in that area, where we're finding that there is perhaps better communication or more proactive care rather than just the need for reactive care in crisis management. Hopefully that'll lift outcomes for people living in aged care homes.
That's right. And as an experienced clinician, you've seen the changes from the ground up. And I guess, everyone's talking about, it's December now. So the November 1st legislative changes, they were designed to strengthen clinical care. But what improvements are already emerging inside homes that you can see?
Mark, I think what I have noticed is perhaps what we call people employed to provide lifestyle support, while I've noticed that their clinical skill level is low, but there's more people attributed to providing those services. People living in aged care homes, one of the biggest factor, and for all of us, is mental, social, physical well-being. And so, just of this last month, and a few homes have noticed the increase in people who are employed by the home to provide lifestyle services. I'm hopeful that that's going to lead to improvement in people's general well-being.
Correct. And there's a massive focus now on lifestyle. I think years ago there was a bigger shift on this is a place where our older Australians and other cultures, sort of go and they're there. But now it's a case of looking at it, like you said, holistically, especially from a lifestyle perspective. And, the days of COVID and, gastro outbreaks and that sort of social isolation, really placing a bigger focus and emphasis on what sort of engagement levels there are, and are people happy, and are they engaged? So it's very, very well said. I agree. I completely agree.
Yeah. Thanks, Mark. Yeah, it's absolutely, yeah. Well-being, I think, and I'm hopeful that in general we'll make a big shift from seeing entering aged care home or living in aged care home being sort of your end of life versus actually being a stage of life, albeit perhaps your last stage of life, and so that we can treat, and people who live in there are treated accordingly, because it's the next stage of their life.
That's right. Correct. I agree. And, you've always been championing that sort of GP and nurse practitioner collaboration. But as we know, outcomes improve when roles blend rather than clash. Where are you seeing the best examples of nurse practitioners and GPs working together to generally lift resident outcomes?
Yeah, Mark, I think, the model that and this is a bias, so I apologize, but the model that Elite Care Health does promote, and that I have championed, is where in the past there was something called collaborative care, where a nurse practitioner had to work with a GP. There is not that requirement anymore, but I still believe collaboration in the true sense is critical. So including, using a single, if possible, EMR, where both nurse practitioner and GPs can refer to patient notes, where there is not necessarily a delineation of roles, but where there is an overlap of roles, but it is very clear that there's not a doubling up. And so I work really well with two nurse practitioners at the moment, and I know some other GPs do. So where we don't double up on the work that we do, but we know exactly who's doing what, and so we can provide holistic care from on a multidimensional and multidisciplinary point of view.
Elite Care Health is a team of nurse practitioners and doctors who provide medical services to aged care facilities across Sydney. We support residents with in-person visits, phone care, and video consultations, whatever the facility needs. For more information, contact us through our website at echhealth.com.au or call us on 02 8357 3367. Elite Care Health, caring with compassion.
That's right. Yeah. Sorry, go on, Harsh.
No, absolutely.
No, I think you're right. I think you're right when we're talking about AI and how we can work collaboratively and having a single sort of platform when you're talking about EMR and having access to data. But you're correct, there needs to be clear defined roles. I completely agree with that. And also that escalation when, as a clinician, I'm non-practicing, but we always talk about scope of practice, right? So we never try and be a hero. And there are times where, especially as a nurse, and we've always gone to our GPs, to our doctors, if it's in the hospital, the registrars, or even junior house officers, whoever's around, say, look, this is completely out of my scope. What to, and they'll provide that sort of clinical roadmap of what needs to happen. So I think you're very right in terms of that collaborative approach and effectiveness of the roles.
Yeah, absolutely.
And I think, we always talk about, clinical leadership, and leadership always sets the tone. But what qualities do you see in the strongest clinical leaders in aged care?
Look, I think so, because we're focusing on clinical leaders, I think passion and compassion. So because it's a very passionate, when I mean passion, I mean people who are driven by positive outcomes for their patients. And why passion is required is because it's not a quick industry to move, and to enact any simple change requires a lot of ongoing follow up and ongoing push for change. But on the other hand, visible people being visible, being calm, and visibility, is one of the reasons I appreciate you inviting me to do this, is so that as clinicians we can become visible,
Sure.
uh, and obvious that we do care about our patients, and we want results, and if anyone is data driven, it's clinicians, and so I think that's a big thing for clinical clinicians to be able to be leaders in the industry.
That's right.
Yeah.
Correct. I agree. And, I think when you're talking about the changes in legislation and compliance, I know one of the sort of big questions and topics really is medication safety. When I was a facility manager, there has been times where we never want to do it, but it's that, notification of lost drugs that we have to send through and there's a whole sort of thing and, course that needs to follow. But even, best practice in terms of medication safety, it's still one of the biggest risks and I guess opportunities to improve. What's one practical habit or system you've seen that significantly improves medication safety?
Look, I think reconciliation, for me, it's something that I've always practiced. I encourage other practitioners to do, is regular reconciliation, identifying medications that are prescribed to clinical reasons, why they're being prescribed, all clinical history, and whether it correlates back to the medications patients are on. We do deal with an age group that requires a lot of deprescribings. And when I talk about reconciliation, I mean a lot alongside the electronic national residential medication chart, which has been extremely helpful, actually, is making sure that we're on top of those things. But when we've got new admissions, hospital discharges, that we are reconciling regularly. And so too, there's a double check between pharmacists and the nursing staff at nursing homes that will lead to fewer medication errors.
No, I agree. I think it's important. We need to constantly have that mindset that we need to grow, right? That we need to learn. I think it becomes a bit dangerous when we think we're invincible clinically. There's always someone that can teach us, or there's always, even now we have a sounding board of how we can improve practice, but especially pertaining to medication, I agree. You're very right in terms of the approach. And you touched on it there with the word innovation. But as we know, unfortunately, not every innovation lands, but some genuinely help. What's the most effective innovation, whether it's technology, workflow, or comms, communication, that helped you support residents more efficiently?
Maybe we should talk about the opposite, Mark, but that's not the scope for today. Look, I think communication did one of the things, as we said, is the electronic national residential medication chart. That has been, I think, extremely valuable in reducing medication errors, but also helping us clinicians and overall as teams know exactly what sort of medications people are on and using. But digital communications, including medication, or not medication, so medical records, and that's both from a GP's point of view, using programs like Best Practice or Medical Director. On the other hand, nursing homes using their multitude of electronic medication record keeping. I think that helps keep a streamline of communication rather than notes going missing and communication going missing. Secure Google Docs has been extremely useful in communication between nursing and medical staff. And then once somebody can produce a software that we can all globally communicate on one platform, would be much better.
That's
At the
right.
moment, we've got multiples, but it still works better than handwritten notes.
Correct. So I remember gone are the days of handwritten notes. That's probably the only time I've been likened to a doctor, Harsh, with my handwriting. It's not very legible. I agree. Once we can sort of have a uniform system where we talk about this a lot, that multidisciplinary team approach, where it's simple, where, you as a doctor talks to the pharmacy, talks to the team, the families know what they need to know, they're aware, updating care plans, etc., any consent forms, it will make, life much easier.
Yeah.
Maybe the word which a lot of homes don't like to hear, accreditation, when the Aged Care Quality and Safety Commission come in, and it's something which can unite a team or break one apart. When you've been involved with homes during accreditation, what approaches have you seen firsthand that help teams feel prepared rather than pressured?
Yeah, that's a good one, Mark, because look, as a GP, I'm not paid to help a nursing home undergo accreditation.
That's right.
And so where it actually works really well is where homes have look at accreditation not as an event but as an everyday practice, because accreditation is there to make sure that the safety and well-being of residents is maintained at the highest standard. And so where that's maintained on a day-by-day basis, as a clinician I can provide that care. And so I think the biggest part is where on a day-to-day basis we uphold the standards that any organization sets. Is a much better way, and where there's transparency, reduces stress dramatically. Um,
So that's a good point. And you mentioned about, obviously, when there's transparency, we talk a lot about open disclosure, with the aged care standards. And on the subject of families, families today are more engaged than ever. And, their knowledge is available. They're Googling certain things. There might be certain disinformation, or they're, having corridor chats with other family members. But
yeah.
what approaches do you believe help build trust and transparency with families?
Look, one of the big pet loves or pet peeves is look, clear, transparent communication with families, and whether that's a phone call to the family, and whether that's it doesn't have to be by the GP, it doesn't have to be by the nurse practitioner, but really mostly by the nursing home or the registered nurse at the home. With family, and even minor things, it helps build trust. And when done regularly based on what communication style the families require, it creates rapport, it helps outcomes in general, helps, meeting the goals or the care needs of the resident, rather than so we become more patient centered, so to say, rather than institution centered in care. Yeah.
Very well said. And, I think when we're talking about the teams and the people that provide the care, and they're in the coalface in terms of workforce, I know for a fact, and it's almost, identical in the UK. If we didn't have our, migrant staff, workforce in some place in the UK, and also here in Australia, talking about Australia, there would be no workforce. As simple as that, especially rural communities. In a way, we're indebted to the workforce for, the work they do. And I think, my father's Sri Lankan, mother's West Indian, but especially, speaking broadly in terms of Asia, it's innate, cultural ability. Back home, if we have our parents or grandparents living at home, that's a blessing. So providing that care, that sort of that nurturing, that soft nature, that's part of, I guess, the DNA of most of our care workers. What do you think the sector's doing well in attracting and retaining, skilled staff? And two-part question. And what would you believe would accelerate progress in that aspect?
Yeah, look, Mark, this is a good question. Because I'm not directly involved, I can just state from observation.
Yes.
What I've seen is where there's, in terms of attracting staff, is where there's clear career pathways, the option to upskill, and that attracts people, because most people want to move forward with their life and start young in the career. And so where there's clear pathways, people tend to come on board more. However, alongside that, then the second question of the same question is, how do you keep these same people on? And I think that's where a lot of places that are good at bringing staff on and really bad at keeping them is because things where support and mentorship, ongoing training would be the facts or factors that would be able to keep somebody on, offering them variety of roles. And diversity in experience would be a key factor to keep people on. Also, moving people forward in their roles too quick chases people away. it's a good one to bring them on board, but it chases people away because taking on too much too quick and people get scared. And I've noticed that in a few places that I visit, where people get given roles when they're very junior,
Mhm.
tend to get really scared and run fast.
That's a real valid point and a real truth. And I'm glad that you shared that. And I call that the fear factor, where, there could be an RN that's just sort of qualified, they're fresh, printed off their ARPA registration off the printer. And within 6 months, they've been stepped up because there's no one else, sort of thing, especially in the
Yeah.
rural area, as a clinical care coordinator, as a care manager. And
Yes.
they're still trying to find, learn the ropes themselves. They're still, even though they're confident, they still sort of, have those P plates on. They want to see someone to supervise or support them in their decision making, but they're the ones making the decisions. And we go back to that sort of fight or flight. And unfortunately, they tend to do the latter. So you're very right in what you've said. I agree. What's one truth about aged care no one wants to say out loud?
I think aged care has got a negative perspective in terms of it is seen as the end stage of life. So historically, it has been seen as where you go to die, and therefore has a very negative connotation. I must say, as I said previously in our chat today, Mark, is I think we need to perceive this as another phase of life, another stage of life, albeit the last stage of life, and where we treat people with dignity and respect. I think the whole ethos of the workforce will improve. And I think at the moment we just have a very negative perspective about aged care, and I must say it's not being driven well on a public scale. Yeah, so that's the reality. Most doctors don't want to enter aged care because they think it's too hard, it's too horrible, and because most people don't want to deal with death, um,
Right.
and it's faced very often in aged care.
That's right. What's something you wish every aged care home understood about GP collaboration?
I think if so, the College of General Practice released a standards for accreditation that aligned a little bit with the Aged Care Quality Safety Commission standards of accreditation for nursing homes. If nursing homes did align a little closer to those standards by the RSEGP, I think a lot more GPs would be attracted to attend nursing homes. I often, I often I ask, I'll often ask the facility manager, I said, if your CEO walked in today, would you offer them a cup of tea or coffee? I said, of course. I'd offer them a chair to sit, etc. I said, then what do you do for the GP that walks in? It'd be hard for a GP to even attract a hello, let alone a chair and a cup of coffee. So I think if we want people to remain within an industry and keep serving that, then you treat them with a due respect, because these same GPs have a reserved parking spot, have an office of their own when they go to their own general practice. They've got reception staff, they've got nursing staff to wait on them, but they don't get that in the nursing home. And so a lot of GPs go, why should I bother going when I'm paid exactly the same, but given less respect? That would be my throughout.
Yeah, no. I think, especially speaking from, my experience, we had great relationships with our GPs. They were there for years, but it was that, collaboration and where, we'd know about their families, we talk about each other's kids, those sort of things. And we would invite them to, the Christmas party if they could attend. They're very busy, as you know. But it was just that sort of, we didn't see them as an add-on. They were integrated within our service. So even when there was an outbreak, obviously we'd inform them, even when it came down to certain meetings, and we'd try to see whether they could be there for our MAC meetings as well, if possible as well, even for a short time, whether they dial in via telehealth. But it was about that inclusive approach, and they're great. That kind of stewardship they provided, and they really, honestly, even to some of the junior nurses, and you have to understand that that's what I found amazing, that the GPs there, they were almost, imparting knowledge onto, the nurses, the clinical team, as if they were medical students, but they weren't. But it was just that kind of, this is what you should learn about, in a very respectful way. And there was great collaboration, but I agree, it needs to be easier. We need to be better at attracting more GPs, to resi aged care, there needs to be definitely that shared respect, and it's it's an absolutely essential service. So which prompts me to the next question of timely GP access. It's more of a scenario based question where you're on the front line and it's a make or break issue. What does timely GP access look like in a modern aged care environment?
Yeah, Mark. I mean, again, this goes back to the RSCGP standards, and they have defined, what would be considered reasonable access. And I, speaking from my own experience, with most of the homes we visit, between myself and nurse practitioner, we provide a weekly visit to each home. We also have a dedicated time for what we call telehealth. So for the homes that we're not visiting through the week, we've got a dedicated amount of time where the nursing home can contact us for concerns that can't wait till the following visit. And I think that is reasonable. What often can also happen is the expectation of the GP to be available 24/7 detracts GPs from again serving nursing homes or resi aged care homes. So I think general, if there is simple rules as guided by the College of General Practice, and we'll have a lot more people and a lot more people looked after, a lot more people serving, and a lot more people looked after better.
I agree, and there is that kind of we have an issue. We expect to call a GP at 2 a.m. or something, but there needs to be a triage process. There needs to be an escalation of risk. And often it comes down to not at a head office level, but at what's the local clinical governance?
Yeah.
Where's the escalation points? What happens here? So I agree. There needs to be, clear processes. The same way in primary healthcare, we talk about the hospital, so an emergency, you're triaged and depending on your risk, and what kind of symptoms you're having, a broken arm versus someone with cardiac issues, they're going to be treated differently. But I think the same way with resi care, I often feel not all the time, but in most instances, it comes down to a deficit into the clinical education. So
Absolutely, Mark. I mean, that's one of the biggest things is wherever I find there's very junior nurses unsupported, there's a lot more panic, a lot more phone calls, a lot more emails. But one thing I've always endorsed back to is in Australia we've got Health Direct, which
yes,
can really help triage concerns. Whether you're a clinician or non-clinician, Health Direct is extremely useful. So I've often referred nurses on there when they're not feeling supported.
no, that's great. It's another point of contact, but correct. And they're a 24-hour service, so
It's,
well mentioned. And it's a common part of, I guess, care, especially in residential aged care, which is dementia care. And if we shift into dementia care now into the conversation, something every home navigates, daily. But from your perspective, and we're talking non-pharmacological here, what non-pharmacological strategies, do you see that have made sort of the biggest difference? I know it's sort of one size fits all, but
yeah. So yeah, Mark, you're right. Dementia is just so specific to each individual. So I would say the most effective strategy is the one that's personalized to that patient or to that person. And a lot of it. So I'm one of the very few doctors that runs at least an annual multidisciplinary case conference for a lot of my residents, and it becomes very obvious that understanding where somebody comes from, how they live, what sort of lifestyle they led, what sort of personality they had, what their personal preferences with food, with music, with TV, what things they got annoyed about and didn't. And once those things actually get input into a person's care, they seem to make a whole lot of difference. Obviously, consistency of staffing helps. Some places are using Montessori programs for memory stimulation and so on. So that's quite helpful. Some places use a program of having a regular buddy with people struggling with dementia, and that creates a lot of non-pharmacological behavior management, but also social stimulation, mental stimulation, and physical stimulation. Because once you can manage those things adequately, you find the behaviors start to settle and are manageable a lot easier.
no, I agree. Very, very, very diplomatically said that the one that's personalized, to everyone's case, which is true. We can't gone with the days where diagnosis, medication, treatment, it's so specific now. This could be certain triggers, or there have to be so many multitude of assessments to be completed before, sometimes arrives at a decision, and it comes down to discretion of each practitioner, right? In terms of your approach.
Yeah, absolutely, absolutely. I think beyond each practitioner, I think it needs to be a universal approach, just to move away. And we have, I think, in Australia, one of the best things so far is we are moving more and more away from sedative hypnotics and
Correct.
antipsychotics. So that's a great place we're moving to.
I agree. I once managed a home. There was a lot of, I guess, behaviors, if that's the word that we
Yeah.
use, and the rate of psychotropic medication was about 64%. It was pretty high, and it was a very challenging home for the staff. Staff used to get, unfortunately, assaulted, and it was very sort of challenging to
Mm.
manage. But often, as you know, depending on different diagnoses, and that had obviously dementia aside, treatment resistant schizophrenia, a lot of different sort of profiles of residents. I don't believe it was the right environment for all residents, to sort of
No, no.
remain.
No, look, I think, Mark, one of the things in Australia, in the general population, if we look at psychotropics, they're quite widely used.
Yes.
Psychotropics themselves, I think, are a very wrong definition for a measure. And I know the Aged Care Quality Safety Commission looks at psychotropics. I would more be interested in knowing what the usage of behavior modifying drugs are versus psychotropics, because an antidepressant is considered a psychotropic.
Correct.
But if we look at the use of antidepressants in Australia as a general population, I think it would be similar to about 40 to 60%, which is used in aged care.
True. It's true.
So, Mark, that's been one of the things that, as clinicians, geriatricians, GPs, psychiatrists, we constantly approach the Aged Care Commission, or the definition of psychotropics and consent and restraint.
Yeah. So good point, Harsh. And I guess, as opposed to a blanket, but looking, specifically, like you mentioned, the same way with things like, carbamazepine, and if someone has epilepsy, well,
Yeah,
primary use is to treat epilepsy. It's not a mood stabilizer in that respect. So I agree. You should actually look at it in a more specific way rather than a helicopter view. That's a very good point and a very good perspective as well. So I think what you've mentioned there is the actual metric, like how are we measuring this? That's a good point. If we zoom out a little bit here,
yeah.
and we look at the sort of 5-year future, what excites you the most about the future of aged care over the next 5 years?
Well, what I'd hope, and what I'm looking for, is integration. Is where we can have, and I think digital care is what's going to bring this, or integrated digital care, should I say, um, is what's going to open up the world in aged care. Is where there is a single platform, whether it's for families to look into what's happening with their loved ones, assuming consent, of course, whether it's a clinician who's looking after the patient, whether it's a nurse who's in the home. Because at the moment, we've got multiple medication record systems, we've got multiple medical record systems, and then you've got the record systems that different clinicians keep. And so at the moment, we're in I would call it, we've got a curry of systems, which creates four big, I think, error or missed opportunities. And if I look 5 years ahead, I was working with an organization, well, we were trying to work with an organization which had the capacity to do that, but they just didn't have the funding.
Right.
And it would cost them about $100 million a month to bring this to play, but they could not get the funding. So they had to shut down operation. So it's a big, big sector. The people are there, the knowledge is there, the concept is there, the want and desire is there by people, but the funding and the roadmap is not. So 5 years, I think, is a good time frame to bring that into reality.
That's right. That's right. What gives you hope right now?
What gives me hope is that we're all getting older, and one day many of us, or our parents, like I was saying, are going to be there, and 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 if we what drives me, or what gives me hope along that, is is being able to create a community of clinicians where we're dedicated to providing the better care, and that will create great outcomes for us. So I'm very hopeful with that. Is, as we come together, we, even as clinicians, not even as GP nurse practitioner collaboration, but as GPs, we start to collaborate more, and work together towards a common collective. I think that will give a lot of better outcomes, and so I'm very hopeful that we're moving in that direction.
No, that's great. It's good to see that progression into the future, especially with tech. And I guess, when we're talking about change, sometimes it's the simplest sort of shifts that move the needle, pardon the pun. And what's one simple change that every home could make tomorrow to improve clinical care?
I think if they just if handover they handed over better from shift to shift, whether that's by way of a clinical huddle or a written handover, that would make, from my point of view, that would make a huge difference in care. Because handover is not only, medical concerns, handover is what someone has eaten, what they haven't, if there's a concern with that. So just better clinical handover, or better handover in whole. Some people call it a clinical huddle, or a better structured clinical huddle. That would make a difference starting tonight.
That's right. We've all been in that very stuffy room during handover, and sometimes it's really comprehensive, and you know exactly what's happening. It's almost like a good author, and you're sort of immersed in a book. And other times you feel, especially if it's an agency, that they would not have a clue. They would
Yeah.
just be, sort of working, as they see it, very reactively, as opposed to that preventative sort of care. But you're very right. We're talking about food and fluid charts, what people have been eating, especially if they're hopefully not, but if they're at that stage, pre sort of going palliative, or has there been a serious sort of deterioration, or, I think it's important, but you're right. Having a better approach, we can definitely do that better. What's, I guess, the hardest moment you faced working across multiple homes as a general practitioner?
I think, look, because I've been doing it so long, I've learned to adapt. Not fully. Let me be honest, not at all fully, but adaptation's been one of the biggest things. But what I've alluded to a number of times is improving digital health, or improving technology. One of the biggest things. So I currently use about 4 ENRMC, electronic national or residential medication charts. I use about 5 EMRs for 9 homes.
Right.
So that's what I call it. It's going to cause problems.
Right. Correct.
Until the challenge with this is that they're all separate businesses. And so no one will want to collaborate with the other, because that means giving up power and control. So I don't see them coming together. But if there is a bridge between multiple of these, from the doctor bridge to the home, that would be one of the biggest hurdles overcome.
Correct. It's definitely about streamlining. You just mentioned there across, the multiple homes that you look after, there's a lot of different systems and understanding. And we always talk about, especially in, serious situations, speed, right? Speed's important. And how you can interpret data, how you can interpret a situation. So, I agree. We spoke about this before, and, you're, seasoned general practitioner. You've got years of experience working in different scenarios, and at times, because of your experience, you probably work on autopilot. So that's what happens when you're experienced. But what's your message to, that emerging doctor? Because GPs play a huge role, but not everyone steps into it. So what would you say to GPs who are considering supporting aged care?
So look, I think I would say is that working in aged care is rewarding. It is meaningful. And while this may not be kosher to say, but it is actually flexible, and you get to build. So while it is someone's last stage of life, as I've referred to, but you get to build relationships with people and their families, and those who stay longer, you get to know them quite well. It is very comprehensive care. Now, if I can take this chance to lobby against the college does not see it as comprehensive care. They see it as very niche care. But I think it's where I've experienced the most comprehensive care, all the way from skin problems to chronic problems, so acute to chronic. It's the one place where you get exposure to everything. So if you're interested in overall complex care, it's available. Acute care, it's available, and it's rewarding, like I said. So I would encourage the youngest GP and the college to support young GPs to be trained in providing services to aged care. I don't expect people to do it like I do it full time, but do it 1 day a week or do it 2 days a week, and it can really make a difference. It can prevent burnout. It gives you a new perspective on life, and it just makes you relax and think, life's okay how it is. Um, we are all going to get older. We're all going to reach a certain point, and it's okay.
I agree. And I really like how, you tell it how it is, Ash. Like you've mentioned, obviously, the college, and you talked about the flexibility, which is important. At the end of the day, we're all human beings, right? We have families, we have our own commitments personally. There needs to be that aspect of, yes, we are providing a service, we have a duty of care, but it needs to make sense, right? Otherwise, you just mentioned it, it's going to be like a short-term contract as opposed to something sustainable. And we always talk about those buzzwords, continuity of care, and having someone like yourself who's stayed in the sector. That's what we want for general practitioners to be, their long-term understanding. Unfortunately, residents, the average stay in residential aged care is 18 months, depending on, comorbidities. But having that relationship with the facilities, the families, the community, I think it's crucial. To sort of close this out here, I like to bring it back to the residents and what's, reminder the whole sector should keep front of mind.
Look, this is a big one, and this is what I was talking about in terms of meeting multidisciplinary care, getting to know a person. Is the person who enters aged care has lived a full life. They've lived most of their life before coming there, and if we treat each person as if they're a parent, a partner, having, with dignity, with patience, with respect, I think we'll be able to make a lot better clinical decisions rather than just thinking of them as as another number. And that's been the most rewarding part for me, is as I've got to know each of my patients individually and realizing what their whole life has been about. It would make, I think, front of mind for anybody who's any stakeholders listening to this, any actuarist who's crunching numbers in their room, working out how to help the aged care company make money. I would say just remember, you're looking after somebody who's paid their taxes, that are paying the money that's paying you to work. So look after them and think of them as an individual. I know as businesses they've got to make money. As a doctor, I've got to make money to survive or to live or to have a good life, so to say. But centered to that is that person who is because of why we are here today. So
That's right.
front of mind.
That's right. And, finally, in closing, if you had a chance to, it's quite old school. If you had a chance to write a message now, it's probably be in code, not really buried in the ground. But if you had a chance to write a message which, a doctor, a GP could pick up in 50 years, and you think that would be prevalent to their situation, what would it be?
You can't say just remember they're a person. Remember they're a person. They may not remember who they were, but you can help them live the way they might have been.
Very good. Thanks, Harsh. Appreciate it. Well, it's been a pleasure, and just wanted to say, Harsh, thank you for joining us and for the work you do across the sector. As a previous clinician, and working in the sector as a facility manager, we sincerely appreciate it. And if you're watching or listening, make sure to subscribe and follow us on YouTube and Spotify. This is Talking Aged Care, and we'll see you soon.
Thank you, Mark. Thank you.
This episode of Talking Aged Care is proudly supported by Elite Care Health, a team of nurse practitioners and doctors who provide medical services to aged care facilities across Sydney.